When preparing for neurosurgery exam, embryology can be one of the most intimidating topics for neurosurgeon. The concepts are dense, timelines can be overwhelming to make sense of it all. I'm here to simplify it for you. In this session, I will guide you through the essential parts of embryology that you absolutely need to know to ace your exam, focusing on clarity and exam relevance. I'm Amr Morsi, a neurosurgery clinical fellow and someone who has walked the same challenging path you are on right now. My aim is to make it simple, structured, and more importantly, digestible. What exactly do we need to know? We need to know the embryological stages and the key timelines, and also the clinical correlation and neurosurgical relevance. This is the stages, as we can see. We'll go through them. So in the first week, we have a plastogenesis with the embryo containing 2 layers, and in the gastrulation, the 2 layers become 3 layers by adding mesoderm, and this has happened in the 3rd week. And the defect in this stage can lead to 2 main neurosurgical relevant conditions, which neuroenteric cyst and split cord malformation. So neuroenteric cyst is mainly a CNS cyst lined by epithelium mimicking the GIT, and that's why called neuroenteric cyst. It usually persists and causing current infections and need to be excised the whole tract. For a split cord malformation or dysteatomyelia, there's 2 types, as we know. Type 1, I can look at it as a real type, and the type 2, which is the mild type. So from the cord structure, if we can compare them, both of them, we can see in the type 1, there's 2 separate spinal cords, each on its own dural sac. While in type 2, it's single dural sac and 2 hemichords. There's a bony cartilage and spur in the type 1, where there's no such thing in type 2. That's leading to that in the type 1, we can see more frequently the patient have a weakness and back pain presented with that, while in type 2 can be only incidentally. That's why we opt for surgery with removing the bony spur and to avoid more traction to the cord. This is an MRI showing the split cord malformation type 2, and here an operation opening the dura, able to see the bony spur that we need to completely remove it before we close it. Dorsal induction. So we move on to the next one, which is dorsal induction and primary annulation, which usually happen in between 3rd and 4th week. Simply, we can see the neural plates folding, forming a tube. This is the neural tube with a cranial pore and caudal pore. At the same time, the neural crest, a part of the neural plate, will form the peripheral nervous system. At the same time, there is a small notochord will persist and showing the nucleus pulposus of the intervertebral disc. Let's see what will happen if there is any problems in this stage of embryology. We can see the neural tube formation can be cranial neuropore closure, which happened in 24th, and caudal neuropore, which closed in 26th. So, associated conditions that we will talk about: failure of cranial neuropore will cause anencephaly or encephalocele, 2 different entities, and also failure of caudal neuropore will causing spina bifida, occulta, or aperta. And lastly, we talk about failure of disjunction will lead to dermal sinus tract. Anencephaly. So anencephaly is failure of the neural tube to form in the neuropore, that leading to failure of skull and part of the brain to be formed. Usually that is fatal and usually is typically detected before the birth. And as we said, and then we can see that this defect with the brain tissue and dura and also CSF can be protruding through a defect in the back of the head usually. And that is sac needed to be closed. Repair is possible, and the outcomes is vary according to the size and location of this protruded brain. Moving on to spina bifida. Spina bifida, as we can see, it can be 2 types: occulta, which mean it's hidden in Latin, and aperta, which is myelomeningocele, that we can see an open spinal defect and protruding sac containing spinal cord, meninges, and also CSF. And that can be requiring urgent surgery to close the defect to prevent infection, especially when the rupture of meningocele. But in the last few years, we adapting to do a prenatal surgery which is operating and closing the myelomeningocele while in the prenatal stage, which based on a trial, what's called MUM trial. Also, we need to know that this in type 2, which is the spina bifida aperta myelomeningocele, it's usually associated with hydrocephalus, and that need maybe VP shunt. So comparing both of sides, we can see there is in occulta, it's a small vertebral defect, only maybe a skin stigmata you can see, but no symptoms, can be incidentally discovered later on or can develop in the future to the cord syndrome. While in aperta, it's a large protruding that need an urgent surgery after birth or even prenatal surgery, and usually associated with hydrocephalus. And also, unfortunately, there is a lifelong follow-up needed for the shunt and also for the weakness in the legs and sometimes urinary incontinence. Moving to the third defect, dermal sinus tract from the dorsal induction and primary relation. So in this case, we have a tube tract from the skin to the deeper spine, intradural, and usually it's lined by epithelium, which is pathophysiology based on failure of disjunction between the cutaneous ectoderm and the neuroectoderm. And it can be presented by recurrent infection leading to meningitis and also can lead to potential weakness of the legs. And that surgical removal of whole tract is important, as we can see in this picture. So we're moving on to the next stage with the secondary neurulation. So between the 20th and 48th of days in the embryology formation, the secondary neurulation happened. And usually it's the caudal portion of the neurotube, especially the structure lower to spinal cord, is formed, like sacral and coccygeal segments. The abnormalities can be seen abnormally long spinal cord. We can see persisting terminal ventricles called fifth ventricles. We can also tight phyllium terminal and also terminal myocytocele. Moving to the third one, which is to the next stage, which is the ventral induction. Ventral induction, including vesiculations between the 5th and 10th week. In ventral induction, we can see that the 3 primary brain vesicles and then differentiated to 5 secondary vesicles. So we have 3 primary, forebrain, midbrain, and hindbrain. The forebrain will be further divided to telencephaly, which will cause the cerebrum. Diencephaly will do the thalamus, hypothalamus, and epithalamus. Midbrain, mesencephaly, will go to midbrain. And also the hindbrain will divide to metencephaly, the pons, and the cerebellum, and the myeloencephalin. Myeloencephalin will go to medulla oblongata. So what will happen if there is something wrong happen in that stage? We will have 2 main conditions. Prosencephaly and rhomboencephaly is more clinically relevant and relevant in the exams. Holoprosencephaly, it's an abnormality on the forebrain abnormalities, and that means failure of forebrain to divide, and that was single looped brain structure, and result in facial abnormalities and severe neurological deficits. Other abnormality of the forebrain prosencephaly is the septic-optic pituitary dysplasia, meaning it's an incomplete development of the midline brain structures, and there is affecting the vision, hormonal pituitary, and also developmental delay. What about rhomboencephaly or hindbrain abnormality? We'll have a Dandy-Walker malformation, which is a Vermean agenesis, or enlargement of the fourth ventricle, leading to issues with the motor coordination, balance, and sometimes hydrocephalus. Moving more to the next stage with the neuroproliferation. It happened between the 6th and the 12th weeks. Neuroproliferation is a rapid increase of neural precursor cells in developing brain. It can be hypoproliferation, causing microcephaly, as we can see in this picture, or can be hyperproliferation, causing macrocephaly. Moving to the last one, relevant to the exam, is a neural migration. In the neural migration between the 8th and 20th week, or 2nd and 5th month, the neuroblasts migrate to specific locations in the brain to form neurons, established brain layer structured. What will happen if something wrong happened? There's like 6 main conditions. We can talk about them. The first one is polymicrogyri, which is multiple small gyri separated by small sulci and generating irregularly bumping cortical surface, as we can see. There's excessive small folds and causing intellectual disability and sometimes epilepsy. Second one is schizencephaly. And schizencephaly has abnormal cleft or splits lined by a gray matter, resulting in developmental delay and motor impairment. As we can see, this is the schizencephaly. Can be a closed or open lip. This is the open lip and this is the closed lip. Next is gray matter heterotropia, where the gray matter in abnormal locations in the brain, as we can see here, intraventricular or preventricular area, this is considered gray matter heterotropia. The fourth one is lysencephaly, which is in Latin called smooth brain, where we have a lack of normal folds, gyri, leading to severe developmental and motor issues. As we can see, there is only 2 or 3 gyri. So there's another closed entity, but usually can be differentiated from the schizencephaly. It's a poor encephaly, which is a rare congenital disease that happens from encephalomalacia during early part of the life of the baby. And it can be usually seen in the CT scan or MRI and usually communicating to the ventricles. And it's a result from ischemic insult. There's another exam relevant, will be our final talk about it, is poor encephaly, arachnoid cyst, and schizencephaly. This is the 3 little bit close and have some similarities and differences between them. So for poor encephaly, as we said, it's a cystic cavities within the cerebral hemisphere, often communicate with the ventricular system or subarachnoid, and it's usually caused by vascular insults like a stroke during fetal or neonatal period. While in arachnoid cyst, it's a cerebrospinal fluid sacs located in the arachnoid membrane, and it really results from the arachnoid membrane splitting abnormality or CSF abnormalities. And that can be defined as extra-axial CSF filled cyst, and you typically don't enhance and typically not in communicating with the ventricles. While schizencephaly, as we talk, it's a gray matter-lined clefts splitting the cerebral cortex and usually extend to the ventricular surface to the from the ventricular surface to PL surface, and that leading to developmental malformation. And the clinical presentation of poor encephaly is based on the size and the location of this poor encephalic cyst. And in arachnoid cyst is usually asymptomatic and incidentally discovered, and schizencephaly usually present with a developmental delay, seizures, and all motor deficits. Last topic we talk about it, which is also another can result from defect or abnormality in the neural migration, and it's a agenesis of corpus callosum. It's occurred between 8th and 10th week due to defect in tissue and issues in neural migration, and usually present with a developmental delay and seizure and motor coordination. And there is a main thing we can see in the MRI in the coronal suture, which is the Viking helmet sign, which is the unique appearance of the brain lateral ventricles. And we can see the 2 lateral ventricles, frontal horns, can be shaped like a Viking helmet, flaring outwards. Let's have fun and go through 3 quick questions just to know how the questions would come for embryology. At what gestational date does the posterior neuropore close? 16, 28th, 22, and 24th, and 28th. You can stop the video if you're watching now and try to guess the right time. It's the 28th day. During primary neurulation, the neuropore closure at the middle of 20 days, but the anterior neuropore or cranial neuropore will close in 24, while the posterior neuropore will be in 28th day. Next questions. Abnormality seen in this MRI occurred at which gestational age? It's between 8th and 20th week. Agenesis of corpus callosum can be due to defect in neural migration. Abnormality seen in this picture below occurred at which stage? It's a primary neurulation. Myeloangiopathy is caused by failure of closure of caudal neuropore, usually at the 28th day. Thank you. We have covered a lot today, from gastrulation to neural migration, breaking down complex embryological process into simpler exam-focused insights. Remember, the key is to understand what's the initial stage, simple understanding, and what's the pathology that can happen and can be clinically relevant. My hope that now you feel more confident tackling this topic in your exam preparation. Before you go, I would like to hear your feedback. Your thoughts are invaluable. I included here the QR code in the slide for a quick 1-minute feedback. Once you form filled and submitted, you can download you will have a direct link to download the presentation slides for review. Thank you for your time and best of luck with your exam.